Okay, everyone, this is Howard. I'll be moderating this week. Travis is on, and I have some cases as well. But Travis, would you like to go and start this week?
Sure, I can show some.
Great, here we go. All right, thank you.
All right, let's see. I'm gonna hide get back to this list and hide these. Do you see my screen?
Yep, we do, thanks.
Now, this first case is a really cool case that I've seen in the past, and my fellow Kim just brought this to my attention this morning. I'm going to show you old CTs first, and you can see that this patient has an occluded superior vena cava and lots of collaterals in the chest wall. They have end-stage renal disease, and they have this right-sided effusion that's been chronic, and it was getting worse. So this was back in February of this year, and you can see he's got a little bit of septal thickening and some peribronchial fluid cuffs that we'll come back to in a moment. But his effusion is still there a few months later, and they tap it, and they keep getting chylous effusions. And so the first part of this is that he has a recurrent chylous effusion, which has been reported in case reports due to SVC syndrome. So this was the first case of this I had ever encountered. They tried to do an angioplasty and open up his SVC, which I guess they were able to recanalize it for a while, but his chylous effusion never went away. So this is a study from a couple weeks ago, and you'll see here that maybe a little bit, tiny wisp of contrast maybe getting through the SVC, but still massive collaterals, still has an effusion, now has a pigtail catheter in that lung. And you can see the attenuation of the lung. This is going to be an important point here. This was on I think the 13th of this month. And so here's the study that was done, let me find it, just yesterday. So that was on the 13th. And now look at the attenuation of his lung here. And you can see a marked difference. And he also has more of a crazy paving pattern with septal thickening and fluid cuffs and some ground glass opacity. And so when Kim showed this to me, at first I was wondering, since he has end-stage renal disease, was this just calcification like we've seen with the heart of stone, where you get rapid calcification in the setting of some sort of renal insufficiency and calcium and phosphate imbalance. But as she pointed out, look what you also see in this case, which is a lot of this high-density material along the thoracic duct, and also look at these lymph nodes that are now lighting up like crazy. And so this is all Lipiodol from a lymphangiogram, and what they did, a lymphangiogram, and then they did a direct puncture and coil of the thoracic duct to attempt to cure his chylous effusion. And you can see it's decreased now. He still has the pigtail catheter, and so I don't know if it's worked or not. But what's fascinating about this high attenuation in the lung, this is the CT from the embolization that the lymphangiogram that they did, and you see at the start of the procedure that the lung looks exactly like that other CT, with all of this congestion and crazy paving, and the attenuation of the lung isn't really that impressive. That was done on the 20th, and here it is 2 hours later, and this is during the middle of the procedure, and check out what the lung looks like now. It's starting to become higher attenuation. So this is all Lipiodol that has ended up, I guess, in the lymphatics of the lung, since it's also in these mediastinal nodes, which Lipiodol has been reported to embolize, like in the setting of some sort of arterial embolization, like in the liver. I can't find any reports of it spreading via the lymphatics into the lung like this. Moreover, it's like a retrograde spread into the lymphatics of the lungs, which I just think is fascinating. I've never seen this before. I don't know, Howard, if you've seen anything like this, but this is just crazy. I don't know. Any comments from anybody out there? because I think it's nice that we have the time course and it's consistent with that.
No, I haven't. Is
Yeah.
it pretty much unilateral with respect to both the lung and the nodes? Or is it all seemingly on the
Uh,
right side? No, there's some on the left.
there's a little on the left, yeah, and but he's always had just the chronic right-sided chylous effusion. So
Yeah, that
yeah,
is really interesting.
yeah, I
I
thought that,
can think of another explanation, and it is
no, and I see that David just joined. David, you're there?
Barely, yeah.
All right, let me get you caught up on this case because this maybe you've seen this. This is a patient who has a chronic um, chylothorax on the right from SVC syndrome. And this is an old study that I'm scrolling through here. So this is all chylous effusion. And uh, he looked like this a week ago. He's had a chronic pigtail catheter in there now, and he's got this asymmetric crazy paving and still has a small effusion. But they went in and they did a lymphangiogram and injected Lipiodol into his thoracic duct, and it ended up extending into his lymph nodes, and then the Lipiodol ended up in his lungs, presumably in the lymphatics of his lung, because this is like the time course during the procedure. So this was at the beginning of the lymphangiogram. There's not really anything in there. And then this is a couple hours later, as you can see it in the thoracic duct and in this area, and now the lung is all hyperattenuation, and it continued to worsen over the course of a few days. So,
And nothing on the left.
no, just a little. There's a little bit of high attenuation that ended up not at this time, but on the study that was done yesterday. Now you can see that there is a little bit on the left as well, but not nearly as much as there is on the right. And I was telling Howard that there are case reports of SVC syndrome causing chylous effusion. This patient had actually come to my attention back in the spring when he originally presented with the chylothorax, and we discussed that. But yeah, I just thought this
But
was really
so the
interesting.
lung stuff, don't we think that the lung stuff is embolic? We used to see in the lymphangiogram days, we could see lymphangiographic contrast that it embolized to lungs. And I think that the thoracic duct probably drained the stuff into the venous angle, the stuff like it got into veins, and then it went through the lungs. So I think
Well,
this is
I,
autogenous dissemination to the lungs, probably.
it doesn't really look hematogenous though, and it follows all of these paratracheal lymph nodes accumulated the Lipiodol as well, and the subcarinal nodes. Yeah, because we were talking about that. I mean, yeah, that's more well known is the hematogenous spread, but I'm just wondering if it explains why he's had this chronic crazy paving and congestion too. That it's all been just lymphatic congestion.
Mm-hmm.
And if it's just retrograde filling, because here he was a week ago before the procedure,
Yeah.
and and you can see just how thick his bronchi are. He's got fluid cuffs and he's got crazy paving, and
Uh-huh.
I don't know, but yeah, and this kind of looks more, granted the lung is more collapsed, but it almost looks more like you can tease out interlobular septae here, and
Mm-hmm.
I don't know.
So you're wondering if there's some like lymphangiectasia throughout that lung, and you have these dilated channels that permit the stuff with a
Yeah,
little behind it to sort of just move out retrograde into the lung.
right. Which would
Okay.
also be why he has this chylous effusion, I guess, if he's just got um, lymphatic obstruction.
So the argument against what I was proposing that it be hematogenous was the fact that it was just on the one side, the disease side, and it should have
Hmm.
initially been on both sides if it really had gotten into the bloodstream.
Yeah, I mean, there's a little here, but it was really a slow progression during the procedure
Mm-hmm.
because, yeah, during 2 hours after the start of the procedure, there's just a little on the left and a little on the right, some in the lymph nodes, but it's a progressive uptake in the lymph nodes and the lung over time.
Mm-hmm.
I
So
like that
I don't know.
theory. I like that theory. I've not seen that before, but I think your reasoning is really great. And
Well,
the
yeah,
interesting.
and one of the take-home points is just that I had never known of an association between chylus effusion and superior vena cava syndrome, but there are case reports of it, and that's certainly what it looks like in his case.
Mhm.
But yeah, I don't know. I just thought this was bizarre.
Very, very
So,
interesting.
all right, let's see. What do he? I'm glad David's on here because I'm going to show this. I remember David showed that funky, what looked like a mediastinal mass that I think turned out to be a fibrous tumor. Wasn't that you that showed one a couple of months ago?
Yep, I remember
All
that.
right. Well, here's another funky mass, and you can see you've got a hilum overlay sign. And on the lateral view, sure looks like it could be in the anterior mediastinum or along the mediastinal pleural surface. And this is a 56-year-old woman. And you can see this mass, yeah, again, it's centered at that kind of cardiophrenic angle, maybe anterior mediastinum to the right. And I can tell you it's not a thymoma. It's not a thymic neoplasm. It's got some calcification and little cystic things, because that was going to be my first guess. It's not a fibrous tumor. Anybody else want to guess? There is one little nodule posteriorly here in the pleural space, which was another reason I thought maybe thymoma, an invasive thymoma.
Oh, um,
It's what's the attenuation in the matrix of it? It's
Some of let's see, some of this area is it's 30, 30 to 40, and there are a few areas that are a little bit lower, and then there's some weird linear calcifications through it.
um, hmm. And it's not a. You said it's not a fibrous tumor. It's not a teratoma, and
No,
it's not a hemangioma or lymphangioma.
no.
nope.
Um, it would be unusual for a unicentric Castleman's, but I'm trying to remember if I've ever seen a case that looks like this with the calcium that is a form of unicentric Castleman's disease. But no, that's a stretch.
Yeah.
Um,
Well,
someone
And
has,
the abdomen, nothing in the abdomen creeping up.
nope. They took it out, and it was a mesothelioma, epithelioid type.
ah,
So, so it's. I know we've shown a couple of more mass-like mesotheliomas, but this is another one. Yeah, that would have not been in the top 5 of my differential, but that's what it turned out to be.
Cool.
yeah,
And
yeah.
there was some involvement of the pleura posteriorly too. So yeah, it's just another fooler. But I think yeah, obviously we've seen the rare mesothelioma that gives you more of a mass-like appearance, but this is another one of those.
Was there any asbestos, link in this woman's history?
Not that I could find. No,
And
she's a younger patient.
she's young too.
Yeah,
Yeah. Wow, my goodness.
yeah, I know. So all right, well, I thought of his anterior mediastinal or kind of anterior mediastinal mass. Let's see. Let's see. I'm going to go to this one next. Let's see. Howard, you have several cases to show, or
Yeah, keep going. I just have a few.
okay?
We've got time. David may or may not have any, but keep
Sure.
going. Great.
Yeah, these next two are related, and this is a young girl. She's 16, I think, or 17, and had this chest radiograph for cough, and this was at an outside hospital, and they astutely picked up this abnormal opacity projecting over the heart on the PA view. It is pretty surprising that there's not really any clue on the lateral. It certainly doesn't look like it's anterior mediastinum, and with this location, let's see, it's not really obscuring the descending aortic stripe. Maybe, I don't know, maybe a touch there. But she had two radiographs, and you don't really see anything on the lateral view and pointing to where it actually turns out to be, because this is a posterior mediastinal mass.
It's got an incomplete
Yeah.
border sign consistent with the extrapleural lesion, right? On the radio.
Right.
Yep.
Right. Yeah, that you see some, yeah, it's either extrapleural or abutting or broad-based abutting the pleura. And here you can see it's a unilateral posterior mediastinal mass, and I'll show this one just because it's a very typical look for this in a young patient. You can see it's fairly uniform in its low attenuation, but not, it's not uniform fluid attenuation. So you certainly think about a nerve sheath tumor, and you can see on the coronal view that it's taller than it is wide, so it's more elongated rather than spherical. So that should make you think about something arising from the sympathetic chain, like a ganglioneuroma. And then she underwent MR, and you can see, let's see, I'll just quickly show the MR. You can see that it has some fluid elements in it, and it does enhance pretty avidly after administration of contrast. So they took this out, and this did turn out to be a ganglioneuroma. So it's a very good age range for that, and a good look for that. And I showed that one because I want to, that's kind of to set up this next case. This is one I saw yesterday. And I show this because it's, we often look at the abdomen. This was an outside study. This is a 49-year-old woman, and she has this mass involving her left adrenal gland. I think this is a little vessel above her adrenal gland. And it's very similar in attenuation to that one. It's elongated, and this also turned out to be a ganglioneuroma when they took it out. And so I always thought of them arising from the sympathetic chain, vertically oriented lesions. And this one has a similar morphology. But I found this article from Radiographics about ganglioneuromas and neuroblastomas and whatnot. But I thought it was interesting. I didn't realize that, so the posterior mediastinum is the most common case, but a lot of these do arise from the retroperitoneum or the medulla of the adrenal gland, because you have sympathetic tumor in both of those places. So I didn't realize so many, like this high of a proportion, were actually primary to the adrenal gland. So it's something to think about. And like I said, since we occasionally see the adrenal gland on the chest CT, I figured I would throw that in there. But ganglioneuromas, of course, are more considered benign, since they're entirely mature ganglion cells in Schwannian stroma, as opposed to the ganglioneuroblastomas and neuroblastomas, which are seen in younger patients. But I thought those were just cool, two cool related cases.
Very nice, yeah.
All right, let's see. What do I want to show this one pretty quick. So this is a patient who you can see has had quite a bit of liver surgery. And I don't remember, he has liver disease, which comes into play here, but here he is on the 24th. This was a few months ago, but he would look the same on October 24th too, because on October 26th, you can see he's now intubated in respiratory distress and has this new essential whiteout of the right. You can see a little bit of aerated lung, but there's significant shift of the mediastinum away. He has this new line, which I've seen cases, we've all seen cases of hemothorax from line placement, but certainly you're worried about a hemothorax or rapid accumulation of some fluid. And it turned out that right before a couple of, actually this is the wrong study here, but let's see. Maybe it's this one. No, it's not that one. Okay, well, anyway, a couple hours before this study, he had a percutaneous transhepatic biliary drain placed, which you see here. And so they went back in and did an angiogram, and here, sure enough, you can see that they nicked an intercostal artery from the drainage tube placement. And so that was the cause of his hemothorax. So this was a few hours later in the morning, a couple days ago. But it's a nice, I think, a nice image of the active extravasation from the intercostal artery. And we were talking about this yesterday, that we always try and take care to avoid going right under a rib with our lung biopsies. Fortunately, we've never had complications, and I think it's just because we use a small needle relative to a big tube that you have to dilate in place in there. But this was the culprit vessel, and then they actually embolized two successive intercostal arteries, and there's still a tiny blush in here, but his hemothorax subsequently improved yesterday. So I thought it was a good example with the angiogram correlate.
Yeah.
Of the active extravasation. All right. Yeah, and I'm not sure if any of that also was bile too, because obviously if that drainage catheter went through the chest, some of it could be bile as well. I'm not sure, but that wasn't, they just said it was frankly bloody, which is no surprise. Um,
What
this
was
one
the
also, I'm sorry, David, what?
what was the procedure they were doing?
They did a percutaneous biliary drain placement,
Okay.
that pigtail catheter that was in there. And I don't remember if it was for a cholangiocarcinoma or some other cause of biliary stenosis. I think I pulled up the wrong fluoroscopic study to show you before. And then this one is another one that has a fluoroscopic correlate. And you can see that this is a patient who looks like he has some pulmonary edema when he came in. He's a young patient who had aortic valve endocarditis, and you can see between these two studies that he ended up with a median sternotomy. And the reason for the median sternotomy was not that they were intentionally going to do an open aortic valve replacement, because surgery had actually declined to operate on him at first. And so what they tried to do was a transcatheter aortic valve replacement. And you can see that the valve looks okay here, except that the valve wasn't okay for long, and the valve dislodged, and you can see it kind of bouncing up and down in the aortic annulus. And it eventually, it ended up back in the left ventricle, and they had to go in and do a sternotomy to remove the valve from the left ventricle. So again, my theme of the day with these fluoro images, just showing the how this was inflated and expanded, but it wasn't well seated in the valve. And I think part of that is we're used to seeing these more in patients that have calcified, solidified aortic annulus. And this guy, because he's young, it's not a very, and he's a really large guy too. It's a noisy study, but it wasn't, there wasn't as much purchase there because there's no calcification. And also it's probably that it was friable because he had endocarditis as well. But I thought it was just an interesting fluoro image of that. So, all right.
Yeah, very.
Yeah, so Howard, I will stop there. I can pull up a few more to show after you and David go, or if anybody else is there.
All right. David, do you perhaps see any you want to show this week?
I'll try to get something going here, but I'm scrambling.
I can show a few, and then if you...
Good.
All right. This one is a really interesting progression and appearance of lung fibrosis. So let me bring up the exam from 13, and scrolling through that, we can see findings of a interstitial fibrosing lung disorder, parenchymal reticulation, small foci of subpleural traction bronchiolectasis. The left lung is certainly more affected than the right at that time. Let me go forward in time here to now 2015. Let me just unlink these and show you the previous. So we have 13 and 15. And you can see that there's been substantial progression of fibrosis in the left lung compared to the right. The volume of the lung is reduced. We see a lot of traction bronchiectasis and subpleural bronchiectasis, but substantial progression. So that's March of last year. And then perhaps most impressive yet, this is October of this year. And just look at really no left lung. There are just cystic spaces throughout. So massive honeycombing and traction bronchiectasis. And I've certainly seen a couple cases before of asymmetric fibrosis, perhaps not as dramatic as this one, and how how much lung parenchymal losses occurred on the left side, but I thought this was really impressive. So there are descriptions of asymmetrically severe IPF, and we presume that this is what it is, but this one is very dramatic. Have you ever seen one quite as severe as this, Travis or David? This progression, but this severe in terms of progression over that period of time?
That's pretty impressive.
Yeah.
Yeah, just very, very impressive.
This is another one of those cases that makes me wonder about aspiration as an inciting event. And I know there's a lot of theories about that, but especially when it's this asymmetric.
Yeah. Interestingly, here's just a small cohort of patients with asymmetric fibrosis, and I think, I'm not sure what the bottom line is, but it says, at least in this cohort, there's a statement here, we found no statistically significant differences in the number of exacerbations and gastroesophageal reflux in this group of patients. It's hard to know what to make of a small series, but at least here is a series that did look at patients with asymmetric IPF that I did manage to find.
Oh, good to know.
That was really interesting. Very dramatic case. All right. Here's a really nice case of Poland syndrome. So, the classic findings are at least the perception of asymmetric optical density across the chest here, relatively loosened on the left side compared to the right side. The heart is dextro-positioned. If there's a better way to describe that, let me know, but I just usually describe that as a dextro-positioned heart for the time being. Here I'll bring in the CT to show you the absence of the pectoralis muscles, very striking. The appearance of the chest just happens to have a persistent left superior vena cava. But this is the first case I've seen, and I did look it up subsequently, in which some costal cartilages are absent. So you can see that here. And I did find that, or case reports of that. So this is what a VRT would look like. So that sometimes does occur along with the absence of the pectoralis muscles, absence of one or more costal cartilage on the affected side. And here's a nice example of that. So, and I presume that's a sebaceous cyst. So just a really nice case of Poland syndrome, just happens to have a persistent left SVC. And would you guys agree that this is just called a dextro-positioned heart? It's just rotated. The left hemithorax is maybe a little bit small. But I don't see anything else related to the heart structurally, though. And I just it is a bit dextro-positioned.
Now, the airways are normal. The lungs are typical right and left.
We have bronchi, 2 lobes. Yeah, I believe so. Right middle lobe, lower lobe. Yeah, I think they're okay.
Very cool.
Yeah. And he did have, by description, he did have either fused fingers, syndactyly, or stubby fingers, and there's a term for the combination of the two, and I'm not sure what he had, but he had obviously very typical features of Poland syndrome. So a nice example of that. Here's a nice example of a patient that had big PE, and I'll show you that. And then the question arises, what's natural history of PE? Do they always resolve, and so on and so forth? So here's a nice example of an older person with substantial amount of clot. And as far as I know, this is his first episode of pulmonary embolism. So a substantial clot burden in the pulmonary arteries, particularly on the left side there in the left lower lobe. But you can see there's a lot of clot as well. So what I'll show you next is the follow-up, which now is going to be this month. So let me bring up October alongside that. And here you will see that everything has resolved except for, quite substantially so too, the left lower lobe pulmonary artery. So as we go down here, let me just fix this a little bit for you. Notice how this left lower lobe pulmonary artery really has not opened at all. So there's an abrupt transition between lumen here and just presumably fibrotic thrombotic occlusion of that left lower pulmonary artery, just never opened and remained shut. The other artery that remains shut is the right middle lobe. So right here, there ought to be a vessel, but there isn't. So the right middle lobe pulmonary artery is also occluded. So fibrothrombotic, I'm calling it occlusion of both. I can speculate that maybe some of these small shadows here are just small foci of infarcted lung, but I don't really know that. This little cystic space is new, so one can speculate that maybe there was a little infarction of lung tissue there. And then this is something that Leif is doing quite a bit here. We're doing some pulmonary blood volume maps. So you'll see over here some blackness that corresponds quite nicely to the left lower lobe and a little bit to the right middle lobe. But a nice example of non-resolution, non-fibrinolysis of clot in two locations and complete occlusion of those vessels. Nice example of that phenomenon. All right. This is an interesting case. So this is a person with an elevated right hemidiaphragm, of course. Let me bring alongside the lateral projection as well. So this is the kind of case that I would describe as elevation of a good portion, but not all, of the right hemidiaphragm. The posterior, about 1/4 or so, is not elevated, and the posterior costophrenic sulcus goes to the appropriate position. And when I see this, I suggest eventration rather than paralysis, particularly when the diaphragm doesn't go all the way up posteriorly. So let me bring alongside the sagittal CT. And if we go over there and look at the diaphragm, we can see where it's really thinned in its central portion corresponding to the elevated portion. Notice posteriorly here that we do have some diaphragm muscle. And what I couldn't tell is that there's actually some anteriorly as well. So a good portion, but not all of the diaphragm, is elevated, except for here and there. Now, I noticed in his clinic notes that they variably describe this as paralysis and as eventration. At some point, a fluoro study was done, but here's the pitfall, I think. If you do a fluoro exam and you only do it in the frontal projection, then you will see findings like paradoxical elevation, as you can see there, with what appears to be a sniff, maybe sniffing several times. So that's what I think the person did and diagnosed paralysis. But the pitfall is if you don't try to fluoro in the lateral projection, you won't be able to perceive that while there's paradoxical elevation of this portion of the diaphragm, that this portion here may not be, may still move, or at least it won't go up. So that's really a pitfall. So this was described on the fluoro as paralysis, but I believe it's an eventration. And one of the things that we've talked about before is evaluating the crus. And just to go down to where the crus is, you'll see that there's no atrophy of the crus. And this is the posterior crus over here. So I think this is an eventration, not a paralysis. Now, I'm not sure why he went to surgery, but I think the surgeon just did what was asked, which was a plication. So that was performed. And then sometimes you'll see in the surgical literature that from the point of view of doing a plication, it's sometimes done for both paralysis and eventration. So here's a nice discussion about the different pathologies. But sometimes they say if a judgment is made that this is responsible for the patient's symptoms and so forth, then one can do a plication for either an eventration or a paralysis. But I think this is an eventration, not a paralysis. And I don't know whether his symptoms are going to improve and to what extent his symptoms are even due to this, because apparently there's a note in the chart here that said that this is unchanged from a chest radiograph from 2001, which I couldn't find. So I'm not sure to what extent this person's symptoms are due to this eventration, but I thought this is a really nice example of eventration rather than paralysis. David, I thought you'd like that case.
Absolutely. So it's definitely eventration and it's not paralyzed. And I'm trying not to aspirate here. Paradoxical motion does not equal paralysis. So para does not equal paralysis. So the paras don't go together. It just indicates relative weakness. if you'd done the fluoro and the lateral projection as you pointed out, you would see that you will have contraction of that abnormal hemidiaphragm posteriorly, where that muscle, where you showed on CT, the muscle still is, but you may get paradoxical motion of the anterior part of that hemidiaphragm. So you may get this rocking motion where it moves downward posteriorly, but moves upward the weak anterior thinned area.
Yeah. Certainly that's what I would look for if I did it. It might be hard to discern, but that's what I would look for, as well. Yeah. All right. So I thought a really nice teaching case of eventration and how to think about it. All right. I can go back to Travis. Are you still there, Travis? And want to show a few more and take us through the rest of the hour? Great.
We'll see if I can take up that much time. I may not.
Oh, that's fine.
This one, I was just looking up the path. I don't have the report, but I can tell you what it was. I showed this one a few weeks ago, and this was an incidental finding. This was an MRI done for left atrial mapping for AFib ablation, and there was this mass that was overlooked at the time on this study. This was back from last October, and you can see it's deep to the pectoralis muscle here on the and this is pre-contrast. Post-contrast, you'll see fairly avidly enhances. And so this was brought to our attention back in June. The patient had a CT of his chest, and you can see a similar enhancement pattern. It looked like it was superficial to the ribs and deep to the pectoralis muscle. The good news is it hadn't changed. And this was an outside study that they brought to us for consultation. I guess this is painless. We didn't know what it was. I threw out a large differential, even some weird hemangioma or some sort of mesenchymal tumor. I didn't know, but the fact that it hadn't grown was encouraging. They took it out, and it was an angiofibroma, is what they classified this as. And I'll include the pathology report when I can get it downloaded. But it was a very lengthy pathology differential and final diagnosis. So it makes me think that they weren't exactly sure what it was either. But it had clean margins and looked like it was benign.
Yeah.
But much like our report would have been for this case, just long with a lot of things on it, I think the length of their report was inversely proportional to their degree of confidence as well. So so it was essentially a benign mesenchymal tumor. So I don't know. I don't know anything about angiofibromas really. I'll have to look and see. But that was just follow up on that. This was an interesting one. This is a lady who was neutropenic, not at this time. This was back in March of this year, and this just shows you that her heart looks okay. That's the point of interest in this. And then she was bacteremic and had chest pain, and had this CT done on the 1st of September, and you can see she's got a lot of pericardial thickening and inflammation, and she also has this loculated rim-enhancing fluid collection, and it's hard to precisely localize it because you wonder if it's involving the wall of the left ventricle as well as the pericardial space. It certainly looks like it's centered in the pericardial space, but she was bacteremic, and I don't remember what it was, but she was also DNR-DNI by this point, and you can see over the course of a few days that this enlarged in size, which is kind of interesting. So there are cases of purulent pericarditis where you can get more direct, discrete abscess formation like this. So this is what we thought it was, and here it really looks like it's almost taken a chunk out of the left ventricular wall. I show that because this was actually a month before that. This was in August. This was an outside study that she had that they brought with her, and this was a PE study, and I guess this was not detected at the time, but you can kind of see the start of this, and it looks like there may be some just low attenuation in the wall of her myocardium. This may have been a hematogenous seeding of this area that then evolved into this just ugly looking purulent pericarditis.
So Travis, it's very loculated because most of the anterior pericardium there looks pretty normal.
Yeah, it's a little thickened, or there's a little bit of fluid here, but you're right, it's very loculated. And you can see there's a lot of inflammation I think in both the epicardial and the anterior mediastinal fat. Yeah, and like I said, unfortunately, she was not in any shape to get, her platelet count was close to zero, and she eventually was just sent home on hospice.
Uh-huh.
Yeah, and then it's kind of interesting that you can see it's basically lifting her LAD up too, which is another reason I was wondering if we thought it probably started in the myocardium and
Right.
then just extended into the epicardial space. So, but you're exactly right, David, that it's very loculated, and that's why we think it probably started in the myocardium.
Yeah.
But I think, yeah, at this point, it's like, yeah, it's a purulent myopericarditis, maybe would be a better term for it.
Okay.
But yeah, it's just a very interesting case, and also just subtle on this one. But you know, yeah, unfortunately, we'll never get Path on it, and I don't think she's with us anymore. All right, let's see. Here's one that Howard especially will like, since this is one of our favorite points of discussion. This is a patient who had an outside PE study and was transferred here, and you can see, and this is a pretty almost convincing one, that it looks like this could be a PE in the left upper lobe. Except, as we've seen with a lot of these flow-related artifact cases, when you look at it on more of just a standard soft tissue window, you see that we really don't see this defect, and it's only when you window it, which gives it appearance of being darker than it actually is. And you can see, even when I put a Hounsfield unit on this, that it never really gets below 125. I think there was one pixel that was 105 Hounsfield units, certainly suggesting that this is a flow-related artifact. And when you look on the lung windows, you see that she does have bronchiectasis in this area, and she also has some big bronchial arteries. And furthermore, it looks like there's not a similar attenuation to the aorta. So I think that probably this is due to a contribution from the bronchial arteries and just slow flow. So she was transferred here, with a presumptive diagnosis of pulmonary embolism. Of course, she has hemoptysis, and the last thing you want to do is anticoagulate somebody that has bronchiectasis and hemoptysis. So we did a repeat, and yes, this is a month later, but more of a delayed, and you can see there's nothing there. I don't think they anticoagulated her just because of her hemoptysis, but I'm pretty confident that this was a flow-related artifact from the beginning. So I'm guessing you guys agree.
Yeah, I do. That's a gotcha. That's a good one.
Yeah,
It looks very discreet.
yeah.
Wow.
The did I show you guys a recent case report I found of bronchial artery inflow in this setting
No.
as one of the contributions? Let me pull up my PowerPoint really quick. I'll show you, because this was let's see this. I'll show it because I found one, because I know we've talked about bronchial artery inflow as a cause of one of these, and in the setting of bronchiectasis. This is a case report, and here you can see this is a very good example, very similar to this case I just showed you. Not a lot of flow downstream, and you can see these filling defects.
Hmm.
And what's cool about this is they did delayed imaging, or more arterial phase, aortic phase, with a saline chaser to show the bronchial artery contribution in almost an identical distribution, which I think is probably this case I just showed you. At least a component of it is bronchial artery inflow, in addition to just heterogeneous mixing. But if anybody has a case of this and wants to try and do a saline chaser to really get the contrast out of the pulmonary artery, I suspect you'll see this. I'm going to try it if we can find a case where we have a question in the future. But I thought this was really quite a great illustration of this point.
Mhm.
So
I think
bronchial artery inflow means that there is I'm just thinking out loud here, there's a direct communication between a bronchial artery and that portion of the pulmonary artery.
yes,
And
and
does that
yeah,
just happen spontaneously, or is it known to happen even with the relatively large vessels?
it happens. So I was talking to one of my senior attendings that used to do angiograms all the time, and he said it was very frequent that you would see anastomoses, usually around the segmental or the subsegmental level, especially in patients with bronchiectasis.
Okay.
And here's an angio that I found. This was a patient with HHT and had, hopefully the video is showing up, but this patient had a spontaneous or related to his HHT, I don't know. You can see on this bronchial artery angiogram, you'll see filling of the right lower lobe pulmonary artery here through this connection. You can see it start to opacify.
Okay.
Yeah, I don't have any good one. I'm still looking for a good one in the setting of bronchiectasis, but the point is, in these cases, I think that's one of the contributing factors for causing this, and it's kind of right in that same area. And you can see there's a little bit of contrast in this bronchial artery, and that one doesn't, that's not the exact one that anastomosis with that bronchial artery, or with that pulmonary artery right there, but that's definitely a contributing factor, like that case report I just showed you.
Now that you mention it, I think we did have a patient here not too long ago with cystic fibrosis and hemoptysis.
Mm-hmm.
In that context, they did demonstrate a connection between a bronchial artery branch and a pulmonary artery branch. So certainly one should think of that when there's chronic bronchial inflammation, as opposed to just a normal person, otherwise normal.
Right. And
okay.
I think one of the problems we run into that patients with cystic fibrosis, they'll often, at least here, they'll try and do PE protocol studies, and if you were to time it like this, I think you'd get faked out, or you could potentially get faked out if you're too early in your timing. I think it's better to do aortic phase for those cases, since you're looking for more bronchial artery contribution anyway.
Yeah, that's good.
Yeah, but if you could find that angiogram, Howard, that'd be really interesting to look at.
I'm almost positive I kept the patient's name, so I'll check that out, because now I just remembered that we did have a like that, and I think there were communications in two places, so I'll find it.
Yeah. So, but that case report I found was a really
and the case report, do you recall whether that patient too had chronic bronchial disease, CF or something?
I don't remember. I'll have to pull it up, but I'll show it to you. I think they must have. I mean, they had big bronchial arteries.
Okay.
So, and then
Travis, I could show a couple of cases here if you
okay. Let me show. I'll show this one really quick. Well, okay. I'll let you go. I'll save that one for next week.
Okay. Okay, David, that would be great.
Can you guys see my screen? Do I have to?
Yep.
Okay, here we go.
Yep, we do.
Okay, so this is a fellow who had a bone marrow transplant and has graft versus host disease. He had myelodysplasia, he previously had aplastic anemia. And this is his current radiograph. He's got some respiratory distress. He cannot lie flat. He does have some small pleural effusions. He's got very low lung volume, and he has some basal atelectasis, and he's been looking like this for several weeks. This is a previous radiograph before he had these problems, and you can see he had much more normal lung volume at this point. And this is a CT scan to show what his diaphragm muscle looks like. It's nice and thick. It's actually a little bit thicker than normal, so he's got good-sized, robust-looking crus here. And his CT measurements of his crus are unchanged from exams in 2015 and 2013, so he does not have crus atrophy, but it looks as if he's got a respiratory diaphragm problem here. So he's got that despite having normal crus thickness. Now I'd like to show you his fluoroscopy here. So this is fluoroscopy with a patient. Let me do. This is supine, okay. Okay, so look, I started with this patient standing. He's got the low lung volume, and he had some muscle. He had a little bit of respiratory motion here when he breathes. Let me see if I can do this in loop. You can see his diaphragm moves just a little bit here with him supine. When he was standing, let me do this standing here. So this is standing, and you see he's got somewhat more respiratory excursion here. And it's orthograde, so when he breathes in, his chest wall goes up and his diaphragm goes down. So I'm sorry the motion is jerky here, but you see he's got reduced diaphragm excursion here, but it is orthograde, so he's got some muscle function. He's not paralyzed. if he were completely paralyzed, the diaphragm would be dragged up by his chest wall going up, and we'd see basically paradoxical motion on both sides. When he was put supine, in the previous frames that I showed you, he lost some of this excursion, so it got even worse. So we think this is, I mean, he's got sky-high CPKs and aldolase and so forth. So he's got a myositis here that is involving muscles in his body. He had a hard time putting his arms up over his head for the fluoroscopy, and it's shared by his diaphragm muscle as well. So this is a myopathy probably from his graft versus host disease. Despite the fact that he has normal muscle thickness, he's got reduced muscle function when we look at his diaphragm muscle. So this is the first case I've seen of myositis with profound diaphragm dysfunction like this.
That's impressive. And is that myositis associated in some way with the stem cell transplantation, GVHD, or is it?
Yes, it's thought to be graft versus host disease. And the complicating thing on him is that he's been on a statin for a few months, and so there's some question about whether the statin might be part of his muscle problem, might be contributing to graft versus host disease, and they're going to do a muscle biopsy him because evidently the statin findings of muscle disease are different from what they would expect with graft versus host disease myositis. So we might have some more from a muscle biopsy.
Is it some kind of immune-related myositis that's somehow pathogenetically related to graft versus host disease somehow?
I don't know what the mechanism is, but I would, if it's like other things, there may be a cellular infiltration. Let me show you this other case of a man with a near normal chest radiograph here, but it's got some bone disease. It's got some enlargement of bones and some pathologic fractures. And this is what his CT scan looks like. He's got this low attenuation mediastinal mass, paraspinal masses, things in his spleen, and then huge abdominal mass here with nice little calcifications in it. This is a case of lymphangiomatosis. So this fellow has this from childhood, these big lymphoid, what is it? Lymphangioma collections in his body here, and there's probably a hemangio component. And these calcifications are probably phleboliths associated with that. So they can be combined, lymphangio, hemangio, or hemangio lymphangiomas. So this fellow has that in spades here, and it involves his bone, and that's why he's susceptible to these pathologic fractures. So hemangio lymphangiomas or lymphangiomas here, lymphangiomatosis.
Very impressive. And he doesn't necessarily have the thing called Gorham's disease, which I can't remember, but they have very particular unusual facies and palpable fissures and things like that.
I was looking through his notes and they don't mention that, so I'm not sure how many components of that syndrome he has.
Okay.
He didn't describe any facial abnormalities.
So just a really, wow.
David, does that involve the entirety of the thoracic duct? It looked like as you were scrolling up through the mediastinum that there was, that.
I think he's got stuff all the way along the lymphatics, doesn't he? And it seems to go.
Huh.
I'm trying to remember cases I've ever seen, and there have only been a few of this entity, but I don't remember one having what appeared to be phleboliths. I always thought they were lymphangiomas, but not
That's right.
phlebolith-associated hemangiomas or something. Oh, that's curious.
But sometimes they're combined. They have hemangiomas as well as lymphangiomas. Evidently the embryology is very similar for the lymphatics and the veins, and so they can be combined. So although the path describes the lymphatic tissue, that doesn't necessarily exclude there being venous elements. They can look the same to the pathologist.
Wow, that is very impressive. My goodness.
And one quick question about the last case you showed, David. The pleural effusions, were those attributed to graft versus host disease or just volume overload?
That was probably graft versus host disease too.
Okay.
Because it wasn't volume overloaded, and and these low-level pleural effusions had been there now for a couple of weeks.
Yeah.
And
Yeah,
this fellow is much better on big doses of steroids. His recovering muscle strength, and he's able to get out of bed now and walk around in the hallway.
okay. Yeah, because we've seen a couple cases of at least pleural effusions that were attributed to graft versus host disease, and it
Right.
seems like the temporal course matches with their onset of symptoms too, and they tend to be exudative if I remember. So
Yeah, it's part of it. They can have also pericardial effusions too, so they can be it's kind of a serositis.
yeah,
But there's some of the regimens that they use can also cause a serositis with pericardial and pleural effusions. So I'll have to check to see whether he got those agents.
okay. Great cases, thanks.
Yeah, thank you. Excellent. Thank you very much. All right, everyone. It is 2 o'clock. We saw great cases. Same time next week. Thanks, everyone.
All right,
Now,
thanks.
I did get a
Bye.
message from Norm Thompson, and sorry, Norm, I didn't see that. But Norm, if you're still there, I'll be happy to have you show cases next time. So
All right.
certainly contact me.
All right. Talk to you guys later. Bye-bye.
Thank you.
Thank you.
Bye-bye.